terms of those things that we try to almost do the last surgery first.
Yeah. Okay. No, that's completely fine. I mean, I'm always sort of intrigued as to, how all the various treatments in orthopedic go through cycles. I always say, just beware of the evangelical surgeon. Most of the time we don't know what the hell's going on in everything, and so it's like resurface the patella, don't resurface the patella, do this, do that. They're usually the things where there's multiple options and controversies where you just basically haven't got the answer. So my take on the whole FAI thing, let me share this screen, is also slightly jaded. I've got a reasonable experience with hip scopes. I haven't done hundreds. I've probably done maybe about 100. And I've done very few of the pelvic osteotomies, periacetabular Gans type osteotomies, and I am just a tiny bit circumspect about big osteotomies, especially any osteotomies that are going to cause compromise for hip replacement, because hip replacement is a very good operation, and I think you must just be very wary if you're going to do something that's going to make the future hip replacement operation more tricky or with poorer outcomes. So I'm quite a fan of doing some acetabular work to increase the ability to place a femoral acetabular or an acetabular component for future hip replacement. But I'm very reluctant or slow to do femoral work that's going to bugger up the canal or the neck shaft angle and make stems difficult to do. So that's kind of my disclosure. All right. Okay, is this coming up nicely for you guys? All righty. Let's try and see if I can move your pictures there. Okay, that should be good. All right. So possibly, look, basically, the pathology has been now, documented, has been around for many years, but the recognition of it and then subsequent ability to treat it has only been, it's only about 20 years old. And in South Africa, it's probably 10 years old. But obviously there's all this literature about, in the prehistoric era where these pathologies were being picked up on bones and stuff like that. All right, so actually, a bit of the history of orthopedics is always a little bit interesting and perhaps gets a little bit more interesting as you get older. But anyway, this Reinhold Gans is basically the father of the modern hip or femoral acetabular impingement. I think he was one of the original surgeons who coined the term, and his unit in Switzerland, in Bern, is world renowned for all of these kind of surgeries. All right, so basically you in a nutshell have a ball that impinges against the socket due to some abnormality in its round shape, or you have a socket that is too deep or over covered and then impinges onto the ball or the femoral neck, and limits movement like that. So-called cam and pincer lesion. Have you guys, when did this, who's the, Francis, you must have heard this talk before, eh?
Probably.
Shit.
But Yeah, it's
It
been
feels
a
like
while.
so. It's supposed to be 2 years ago, so this is supposed to be on a 2 year cycle. But jeepers, this feels very recent. Eh? Um, all right. So a cam lesion basically just refers to this kind of oblong shape where there's a decrease in the femoral head neck offset, and the only kind of mechanical variant that I know of where there's cams is in a motor car where the valves on the engine are opened by these little oval or oblong shaped um, discs that rotate on the cam shaft and then open the valves at the correct phase of the piston in the engine. So if you feel interested in mechanics, you can look up that. The interesting thing I think with FAI is in the detective work. Yeah, so as an orthopedic surgeon, it's I sort of find it a little bit frustrating because there's so many different procedures and things that you can do which are quite technically interesting. But yeah, I think you do have to like scope work to really get a buzz out of doing hip arthroscopies. But certainly the mechanical big open surgeries are really nice and mechanically and intuitive and fun to do. But definitely, if you are a bit of a physician diagnostician type of person, it's a really cool field to be involved in because, as you can see, there's a massive differential diagnosis for pain in the groin, basically. Just read through them quickly and see if anything comes to mind. Inflammation of adductor muscles of the thigh, rupture of adductor muscle of the thigh, inflammation of the pubic joint, osteitis pubis, bursitis of the front of the hip joint, other bursitis around the hip, fluid accumulation in the hip, degenerative arthritis, rupture of the superficial hip flexor, rupture of the deep hip flexor, outer snapping, inner snapping, inguinal hernias, stress fractures, nerve entrapment, lumbago piriformis. Okay, yeah. So stress fracture. So this is probably my most recent experience. A few weeks ago, Prof. Roche phoned me and said, "Geez, please, can you see this woman? He's treating her for tennis elbow and golfer's elbow and sort of elbow tendinopathies and inflammatory symptoms. And she's 60 years old, but still kind of running marathons or running half marathons and very active, playing tennis and all of these kind of things. And she has, got excruciating groin pain and also posterior hip pain. And it's pain. It's okay when she's walking around, but as soon as she starts to run and increases the load through the hip joint, it's excruciating pain, really painful, and she has to almost, take weight off the leg completely. So, sort of almost a classic. So usually slightly younger women, kind of 40s, probably maybe hormonal related type of stuff, and definitely exercise related, and they get femoral neck stress fractures, and classically on the medial sort of neck, the the compression part of the femoral neck. Definitely you need to do an MRI scan. So any sort of 40 to 60-year-old woman, especially related to running and weight bearing with groin pain and a normal looking x-ray, you must be very aware and wary of femoral neck stress fractures. And the treatment is strict non-weight bearing, and it can be up to 6 to 12 weeks literally on crutches. So most people will be able to get better with just stopping running and heavy weights or high impact sports. But a period of partial or preferably non-weight bearing, will just make the thing heal up a lot quicker. If you carry on walking around and moving about, it just makes the thing take a bit longer to heal up. And it's quite irritating because you can see the bone bruising. In fact, I just MRI'd the other day another sort of 60-ish year old woman who had a superior pubic ramus stress fracture, basically bone edema, related to repetitive strain, or I can't remember if there was an acute sort of fall or incident. But literally, she's been quite vigilant at having sort of, I can't remember, it was yearly, I think, maybe yearly MRI scans to follow up, and she wants to see what's happening with this bone bruise. So it was diagnosed about 2 years ago. A year ago, she had, the pain was a lot better. She had an MRI, but there was still some signal change in the pubic ramus, or in the pubic bone. And then, like, literally a few weeks ago, she contacted me again, feeling absolutely fine. Still occasional minor pain when doing quite heavy load, but wanted to just repeat the scan. Did another MRI scan, and is completely resolved. So it can take quite a long time if you are not properly resting it. Anyway, that's just recent little anecdotes there. Footballer's groin, also known as Gilmore's groin or athletic pubalgia, is something that we sometimes bounce between general surgeons and the sports physicians. So it also presents quite classically as a groin pain, like a hip problem, but it's usually not associated or exacerbated with the flexion, abduction, internal rotation type movements, so-called fader testing, and more exacerbated with abdominal muscle activation. The general surgeons do, like do these mesh hernia type repairs and fiddle around arthroscopically with the inguinal canal to some degree of success, as far as I know, but I don't really know too much about that. But just remember that is a condition for which was called, that's been around a lot longer than FAI, and patients were prior to maybe 2010 often diagnosed with Gilmore's groin or sports hernia when they actually had femoral-acetabular impingement or labral tears or something. Yeah, I think, I mean, just with all the hip conditions, just remember that limp calendar. So if you 0 to 5, you've got DDH. If you 5 to 10, it's Perthes, and 10 to 15, it's Sufi. So and of course septic arthritis at any of those ages. So just remember that for kids. Yeah, the classic. There's a multitude of tests. Francis and Dane, you would have heard in the clinical meeting today. Michael Helt, he actually mentions this in many times about in the hip examination about the different names of the tests, and I don't know what the hell he's going on about. I mean, there's so many tests in the hip, but I can't remember the names of the specific tests. But the bottom line is that there isn't really a nice pathognomonic feature of patients with symptomatic FAI. It's a syndrome, so you kind of have to link all the history and clinical examination findings together, as well as then special investigations to really try and bed the thing down. And it's quite frustrating because there's certainly a portion of patients who have incidental MRI findings that are suggestive of these kind of pathologies, but if it's not linked with good history or clinical examination, then there's a high sort of risk of dissatisfaction with labral repair surgery, for example. Anyways, I always think of it in two parts, basically the symptoms, what the patient tells you, and the signs. There's usually an inciting type of movement that causes it. So one of the things that is probably, it's kind of gone off the boil recently, but definitely around about 10 years ago, when this whole thing was very new, surf ski and canoe paddling was an extremely popular sport, particularly for sort of middle-aged men. I'm probably actually getting to be old, but actually I would still say I'm middle-aged. But it was definitely a very popular thing, men and women doing canoe or surf ski paddling, and that flexed, adducted, knees together, and there's not really much rotation. It's kind of neutral rotation, but you're sitting in the hip impingement position, as you can see in the picture there, with the guys leaning forward and punching through waves, and so you put in, and so you sort of twist your torso on the pelvis, so you kind of are getting flexion greater than 90 degrees often at the hip, with adduction, knees right together. And this is a kind of a sport or a maneuver, a movement that is not typically recognized as a problem for FAI. So the classic ones are karate, gymnastics, and ballet, where the hip is put into any extreme movements to cause labral damage, and you get the so-called contra-coup injury. So if you aren't butting the femoral neck onto the acetabular rim and damaging the labrum that way, like kickers, the rugby kickers, soccer kickers, as you kick your leg, usually your hip flexes, adducts across the midline, and often internally rotates as you follow through. And so that's a sort of classic position for an acute traumatic labral tear that occurs with impingement. And also then for repetitive strain type thing, you get a contra-coup type injury. So if you ballet dancer or a karate person, and you're doing the splits with particularly both forward flexion extension splits and abduction splits, you can get the hip levering on the outer part of the acetabulum, and then the femoral head sort of subluxing or coming out, so causing the so-called contra-coup injury as it kind of subluxes against the labrum on the anterior acetabulum, to cause it to tear. So the history of the movement is quite important, and then also the specific location of the pain, usually described. So I'll put this in the symptoms column, because this is what the patients will describe to you. So you must actually ask them to point to where the pain is. And the real confusing ones are kind of that middle cross. The classic area is on the anterior thigh, in the middle of the inguinal canal, like the sort of groin, the classic groin area, and anterior thigh pain. Umbilical or periumbilical pain is definitely abdomen related, and then there's this sort of like gray area around about the anterior superior iliac spine and the sort of upper edge of the inguinal canal, flowing down towards the outer ring of the inguinal canal, which then can be both abdominal or hip pathology. Always remember to, and this came up as well in today's clinical exam with Francis and Dane, just be, if you've got limited questions to ask patients, or questions in the exam to ask about, especially trying to differentiate back and hip pain, remember to get the patient to indicate where the pain is, and then you must describe that anatomical location. So the patient holding their hand like that in the picture is not the classic, what they call C sign, where the patient will usually put the fingers facing in the groin and the thumb behind the greater trochanter, and the hand will be lower down. So that picture is depicting much more common gluteus muscle problems, which you can get tendinopathies, or back pain, some referred pain from the back. And then the diagrams on the bottom there are some of the provocative tests to try to elicit pain by, putting the labrum under stretch or irritating the adjacent synovium. So it's always quite tricky for me to figure out what is actually painful. The labrum and the articular cartilage is avascular and aneural, and the adjacent synovium, of course, is very innervated and highly vascular and subject to inflammatory processes. So a torn labrum is usually sensed as being painful because of the associated synovitis, but I don't really know exactly, what is the pain generator, but certainly the movements that try and impinge. The classic left picture there is the flexion, adduction across the midline, and internal rotation. You get the femoral neck to impinge against the anterior superior acetabular rim, which is the classic position for labral tears, and usually tries to pinch or irritate the adjacent synovium, which is inflamed. You can see arthroscopically. External rotation and abduction maneuvers will tend to put a bit more strain or pressure on the whole iliac, hemi-iliac bone and onto the sacroiliac joint. But as you come down into extreme, into extension with extreme external rotation and abduction, you can also stimulate internal hip snapping from the psoas and the iliopsoas muscle and tendon, which can sometimes flick over each other over the anterior part of the femoral head, where it sort of is almost subluxing. You're trying to dislocate the hip out anteriorly as you extend it, and then the femoral head comes very close to the iliopsoas tendon, and can sometimes cause a click or a snap. Best diagnosed with ultrasound, actually dynamic ultrasound. And then examining the hip in extension is I think is important as well. There's a couple of we must do this in the clinical meeting. Maybe just remind me, if you remember, next time when we at the Tuesday meeting, Francis or Dane or whoever's coming there. Today, Francis had a patient with L5, presumed L5 radiculopathy, causing a hip abductor weakness and a mild Trendelenburg positive sign. And then, Maritz was just saying how you must, to properly examine the hip abductors, you must do it with the patient lying on their side and abducting the hip, lifting the leg, away from the midline, off the bed. And like most muscle testing, the best way is to get the patient to get the hip into the position and then ask them to resist you trying to push it down. So that would test, really, it would be a global test of gluteus medius, but particularly the abductor portion of gluteus medius. The other tests that we do a lot in this condition is to stress the various rotator cuff muscles of the hip. So with the patient lying on their side, they would then bend the top leg, the leg you're testing, and put their foot into the bed, and you ask them to hold it there, and you try and internally rotate the hip. So they're basically holding their hip in external rotation. It's probably about 10-20 degrees of flexion at the hip, and then external rotation of a few degrees. So the bottom leg You imagine they're lying on their side, their bottom leg is quite straight, the top leg, the knees are together, their top leg is flexed at the knee, and then you ask them to push their foot into the bed and hold it there, and you try and lift the leg off the bed. So you try and force them into internal rotation, and you can often always palpate posterior to the greater trochanter, and if they've got some weakness of piriformis and the gemelli and obturator internus, the external rotator muscles, or pain, that will be elicited by stressing those muscles. So I first get them to lie on their side, abduct the hip, try to push it down, see if it's sore, if it's weak, put their knees together, flex the leg, push the foot into the bed, so contract their external rotators, try and lift it up, see if they're sore or weak, and then ask them to keep the knees together, lift their foot off into the sky, so they're basically holding the hip in internal rotation, lying on their side, and now they're going to be strongly activating the anterior internal rotator fibers of gluteus medius, and this is the area that is often associated with abductor or hip gluteus medius tears, tendinopathies, and will also often cause pain, as will abduction with trochanteric bursitis. So then with your hand on the greater trochanter, you kind of palpate in the area, let them resist that movement, and see if you can elicit pain or weakness. So we must actually, I'll run through that with you guys the next time. Just remind me, Francis. You must know, I think you definitely, for exams, you must know some of the radiographic features of FAI. So the classic cam lesion, where the head is out of round, seen on an AP X-ray of the femoral neck, but much better on a proper lateral shoot through. And the idea would be to try and get to see the hip in profile, or the femoral neck in true profile. So if the femoral neck version is 10 or 20 degrees, then you would actually ask most patients are around about 10 or 20 degrees femoral neck anteversion. Ask the patient to internally rotate the leg or the knee, so the patella is facing about 10 or 20 degrees towards the midline, and so then the horizontal lateral beam shoot through, so a bit like you would be getting in a DHS, where you take the C arm and you rotate it to parallel to the floor. The X-ray, the best X-ray to ask for is a lateral hip shoot through with 10 degrees of internal rotation, so that you can see the anterior profile of the femoral head neck junction, which is where you're going to best see the anterior cam lesion. And then on the acetabular side, you try and look carefully for the anterior and posterior wall, and the so-called figure of 8 or crossover sign could indicate focal femoral neck retroversion. So, focal superior acetabular retroversion. So the top part of the acetabulum is actually retroverted. There's more anterior coverage from the anterior wall than the normal, circular acetabulum, which has got, whatever, 20 degrees of anteversion normally. And that would then be a feature of pincer impingement. The alpha angle is quite important. Basically measured from a line down the center of the shaft of the femoral neck, in the lateral position, usually done with an MRI. And so a line from the center of the femoral neck to the center of the femoral head, and then it's the acute angle that is made from that line to the line where the femoral head becomes out of round. So where the femoral head basically joins onto the neck. So the smaller the angle, the bigger the femoral head neck offset. The bigger the angle, the less offset there is, and more of a cam lesion. I have now just forgotten the cutoff figure. Who knows? Exam guys. I'll give you
42.
one free piece of advice.
42.
Yeah, thanks. Who said that? I think it's about right. I'll give you one free piece of advice, which may well give you a whole mark in the coming exams. I am an examiner, and I have submitted a question related to the alpha angle. So there you go. Don't tell anyone. And I've actually forgotten exactly the figures, but I think it's something like that. 40 to 55 is definitely, you know, less than 45 is normal. Cool. You guys owe me one, a big one. They might not use it. They might think it's a crap question. Okay, what useful things to say about MRI? Okay. Yeah, cheapers. The MRI. It's actually very tricky to interpret. I think the reality is you just end up having to, you know, just look at a lot of MRIs and then and try and go through it, you know, slice by slice. Yeah, some people. I'm not the greatest 3D reconstructor in my head, you know. So you know, if you have got that skill, then you'll get MRIs a lot quicker. The best 3D mind in my era is JP Duplessis. So he has got an internal CT scanner brain, so he can very quickly reconstruct 3D anatomy in his brain. So if you've got that, that definitely helps for trying to work out where tears are and orientate yourself when it comes to arthroscopy of the hip. But yeah, it's not a strong point of mine. Basically, you must have an arthrogram. So you must do an MRI arthrogram if you want to see proper pathology in the labrum and highlight the tears. I mean, this picture on the top left, I know it's small and a bit grainy and all of that, but with it, the three sort of arrows are showing the cam lesion. So you can imagine drawing an alpha angle there. You know, the head goes out of round by that first arrow. So it's not very many. It's a very high number of degrees. You know, probably close to 90 degrees. I mean that, and there's a massive bump there that you would try and shave off arthroscopically to increase the femoral head neck offset. And then that other longer arrow is showing like the tiny little white contrast sliver, you know, through the acetabulum, the cartilage labral junction where it's got a small tear. So it's often like really subtle features that you have to look at, and so it's much easier if you can really distend the joint with contrast. So we always ask the radiologists to do a MRI arthrogram. Some of the new 3T machines have got very good resolution, and so you don't have to have an arthrogram. They often will report on the labral pathology on the contralateral side as well, if the resolution of the scanner is good. Yeah, I'm not sure. There's not much else to say about the MRI. But basically, you must have an MRI. So we've had a few. There's a couple of. There's one sort of really nasty case in our in Cape Town that happened where the surgeon did, diagnosed FAI or labral tear clinically and went in for a hip scope without an MRI, and it turned out to be a tumor, a pelvic tumor, and it was not lekker. Yeah, okay, so hip arthroscopy is the mainstay or the workhorse nowadays of certainly the labral tear or labral repairs. There's so many things being done through the scope now. I'd say, in my hands, I mean, a lot of the other things like ligamentum teres repairs and reconstructions and stuff is, I don't know, I can't really get too excited about that. But definitely, labral repairs, fairly easy to do, and I think has good results. Acetabular rim osteoplasty or burring down pincer lesions, pretty good, I think, as well. Femoral cam resections, pretty good. So, my arthroscopic procedures are pretty limited to those procedures. And that's a classic view through the arthroscope with the probe in the chondrolabral junction, showing a kind of separation there, which should be nice and smooth and continuous. The femoral head on the right and the acetabulum inferiorly, and then the capsule superiorly. It's very useful, but not mandatory to use a 70-degree scope. If you have ever used a 70-degree scope, it's extremely disorientating. I really struggle. I mean, you need a definitely some kind of brain that works nicely at angles, or a lot of practice. So I actually use a 30-degree scope for most of the hip stuff. There is a 70 available for trying to look around corners a bit, but it's from my hands much easier to use a 30-degree scope. The open surgery is very interesting. The classic procedure is a femoral trochanteric osteotomy with surgical dislocation of the hip. So this is a well-established, I think Sotombo does this a few times for various acetabular things, and bullets and what have you. Very nicely described and reproducible, and very low risk of AVN with preservation of the posterior retinacular arteries, coming from the medial femoral circumflex. So this is just an operation showing, or operative picture showing the femoral head dislocating anteriorly within a chunk of acetabular pincer lesion that's been, osteophyte, basically chiseled off and held in the forceps there, and then the bone anchors inserted into the rim of the acetabulum there to then stitch down the labrum, or you can do this. And most people will do this arthroscopically now, but if you've got large areas that you need to do, it's certainly quicker, I think, to do it open, but obviously it's quite a big cut. And then in principle, this is what you're trying to achieve with the femoral cam osteoplasty. In an open procedure, you can actually get little perspex templates that you can size for the femoral head, and then where that semicircular template bumps into the femoral neck, or basically where that alpha angle should be, and there's a cam, then this acetabular thing will bump into that area, and you can then demarcate. And as you can see on this one, this is huge. It's massive. To do this arthroscopically is tricky. That's a large area to debride. But you can see there's they demarcate quite a big area of what you think is femoral head, but it's actually kind of a, abnormal cartilage over a, or it was not really cartilage, it's just abnormal tissue over a big osteophyte, basically, on the femoral head, on the femoral neck. And then you can see the dramatic reduction in that cam lesion there with the osteotome. Okay. So what is this? So the Warwick Agreement basically I think a lot of these things are really just to remind me to explain to you that this is very much an evolving science, and it is a syndrome, so it's basically a collection of signs and symptoms, and there is not a lot of like very obvious good results, and that's why it requires these consensus statements, because there's a lot of controversy, basically. Okay, so yeah, just a couple of things maybe that you would want to write down or remember. FAI as a syndrome is a motion-related clinical disorder of the hip with a triad of symptoms, clinical signs, and imaging findings, and it represents symptomatic premature contact between the proximal femur and the acetabulum. That's a great definition there. There are a whole lot of consensus statements about how you should come to the diagnosis of it. I think we've kind of mentioned a lot of this before. Basically, you ask the patient about, subjective symptoms, and then you try and elicit clinical signs that support or, corroborate these symptoms or go hand in hand with the symptoms. And then you do imaging to confirm it all. And then, I think these are all things that came out of this Warwick consensus statement, which was done a few years ago. And this is quite a nice summary of the whole thing, is that FAI syndrome can be treated conservatively with rehab or with surgery. And conservative care involves often, and a lot of my patients that I see, it literally is just to explain to them what's going on in terms of that premature contact, and trying to get them to moderate their movements. There's probably, I work quite closely with a biokineticist, so I think the one advantage, look, physios are good as well, but the advantage with biokineticists are that they're much more focused on exercise as a treatment, and so they tend to be very, way better than I am, certainly, at looking for, subtle abnormalities. So we sort of train to, watch the patient walking, and you're looking carefully for, the different type gait patterns, whereas they basically are getting the patient to, run, jump, do the movements of the particular sports that they're doing, and then often using, those foot pads and pressure recordings and, video analysis to work out very subtle, minor alterations in position that can, lead to pathology, and then, work out exercises and ways to train and to move, or help the patients to move to avoid those. So, so I mean, I do actually find that quite interesting, but obviously that's not really my interest. So, I'll usually try and see if the symptoms and the signs are very mild, and not in, really at the level where one should be doing surgery. or if they are a bit disjointed and don't quite tie up with each other, then I will get the patients into into the bio, and basically get the bio to keep them, take them, and then we kind of don't send them back to me. If I've got patients who've got symptoms that are moderate to severe, with signs that are confirming their symptoms, or in keeping with the symptoms that they're getting, and then appropriate MRI and X-ray features, I will often offer them surgery with a very strict pre and post kind of operative exercise and training agreement. So I'll get them to see the bio pre-op for basically prehab, and then post-operatively to try and just help them with all the conservative things to try and optimize that as well. About 5-6 years ago, pre-COVID, we actually did quite a nice callback of 80 hip scope patients that we did it in private, and unfortunately it was the average follow-up time was like just short of a year. So we had some patients out at 2 years, but there were some that were only kind of 6 months. So it was a little bit too short. But basically the sort of take-home message of that follow-up was that we had about 10% of patients who were dissatisfied, and that they were actually no better, or felt no better, and that the surgery had been a waste of time, and or worse. And so that was quite interesting. That's quite a lot worse than hip replacement surgery. And one of the other sort of overwhelming features from that little callback of patients was how long it takes them to get better. We were kind of always pushing, like 2-3 weeks for the stitches, like 6 weeks for the labral repair, and kind of then should be able to get back to full activities around about 2 months, maybe 3 months at the most. And everyone, in that cohort was longer than 3 months. The sort of average duration, and bear in mind, we only really had an average follow-up of 8 months. The average duration that everyone said took them to get back to kind of their plateau level of recovery was 6 months. So that's pretty. It's long. Prognosis. So the thing that what I always tell the patients is that what we do know quite well is that the acute pain of impingement is better. That there's a really good chance that that's going to get better. But the long-term problems of having a labral tear are a little less certain. So if we don't fix your labrum and it remains torn, there's this the theory, of course, that the seal of the femoral head inside the acetabulum and the synovial fluid is disrupted, and there's sort of boundary lubrication rather than fluid film lubrication, because you get escape of the synovial fluid, and this increases wear and leads to increased osteoarthritis, and it's not quite borne out yet in the literature. And we're getting nicely now down to some great randomized studies with labral repair versus labral debridement. and those are getting, those are in the 2000s, and so we're getting to kind of 20-year-ish period now. So it'll be interesting when those things give us some guidance. We're pretty sure that a CAM morphology will result in hip OA. So left untreated, if you have a large CAM lesion, I think there's pretty good consensus that will lead to hip OA. And what remains to be seen is that there's not as good a randomized trials out there for CAM lesion treatment. So debridement versus leaving alone, and then seeing the long-term follow-up. So that has been done with the labrum, but with the CAM lesions, I'm not aware of any of those studies. But I would probably say to patients, I'm much happier to do a hip scope if the patient's got a raging CAM lesion. With or without a labral tear. Most of the time they've got a labral tear. I mean, there's almost always a labral tear. And the question is, you have to repair it or not. So I usually would just repair it because I'm there. But, patients that don't have a big femoral cam and they've just got a labral tear or a smallish labral tear on MRI, I'm slower to offer surgery for those kind of patients. But irritatingly, the femoral cam is painful. When you burr that femur, it's sore. So that's one irritating thing. The patients who just have a labral repair are usually a lot happier immediately. The cam lesion patients, it's quite sore initially to have like that whole sort of periosteum and anterior femoral bone burred away. Yeah, so this is, I think I think this is pretty much, actually, I'll be interested if this came up at all in the talks, the so-called asymptomatic or incidental finding of contralateral side pathology. I think the general feeling still is it's not indicated to offer asymptomatic patients surgery. Was there any talk of that at the Congress, Scott?
Yeah, I think the general consensus, and it was a very strong kind of warning or a instruction, is that you need to have symptoms, despite radiological findings, because you'll always find anatomical variants, and some people might have what appears to be a CAM to you, but they have no impingement. And if you really are kind of on the fence, you can also get dynamic imaging or arthrograms, or like you can always try and look for it. But if there's no real symptoms, then you shouldn't chase trying to correct something that's not causing the patient any pain.
Okay, lekker. Yeah, that's very good. I'm in total agreement with that. There were mutterings, in the early days of this kind of FAR basically, and talks and things about what is it now? What is that condition? I can't remember. This is even before my time, like in the 80s and 90s. It was either it might have been a femoral version problems, like patients with increased femoral neck anteversion, like a whole bunch of asymptomatic patients, or it was valgus, genuine valgus. Anyway, some sort of relatively benignish normal variant of human anatomy that a bunch of orthopedic surgeons got into their head needed to be straightened out or rotated. I can't remember exactly what it was. And there were large numbers of patients that were operated on without any symptoms, to try and sort of make them straight or better. and there was all these unforeseen consequences of, complications and things that, I'm butchering the story, but anyway, it was it was huge warnings when this started to become very popular. Hip scopes and all of that kind of stuff about 10 years ago. Everyone was jumping in the bandwagon doing them, and in fact, the South African Hip Arthroscopy Society has actually got like a list of sort of accredited surgeons. So I think some of the medical aids, I think the med scheme medical aids won't pay for you to do a hip arthroscopy unless you are on their list of accredited surgeons. So so it's quite interesting. It's I think it was at a stage becoming so popular, and everyone was just doing it, and then certainly in South Africa, I think the hip scope guys, just decided to try and sort of keep this from going out of control. Anyway, okay, yeah, and then there's all a whole lot of outcome tools. I mean, yeah, okay, that's the end. Okay, cool.